This is the Onco'Zine Brief with Peter Hofland.
In this edition of the Onco'Zine Brief, I talk with Dr. Ajay Nooka, Associate Professor in the Department of Hematology and Medical Oncology at Emory University School of Medicine in Atlanta, and Dr. Suzanne Trudel, Associate Professor in the Department of Medicine at the University of Toronto and an attending physician at Princess Margaret Cancer Center. We talk about a recently approved drug indicated for the treatment of adult patients with relapsed and or refractory multiple myeloma, a type of hematological cancer in which patients may initially not notice any symptoms. But as the disease progresses, bone pain, anemia, kidney dysfunction, infections and other symptoms may occur. There is no cure, but treatments may slow the progression of the disease. The new drug, called BalanceMap Methotrexate, commercially known as Blendwrap, is an antibody-drug-conjugate which was approved in 2020. The drug was developed by GSK. During the annual meeting of the American Society of Hematology in December 2020, a number of studies were presented which underscored the commitment of the company to advance research across newly diagnosed and relapsed and refractory patients, and to improve the lives of patients with this type of blood cancer. These presentations included a poster presentation of the DREAM6 study and an oral presentation of the Algonquin study, a supportive collaborative study led by the Canadian Melanoma Research Group. Both studies demonstrate the potential of BalanceMap Methotrexate in combination with standard of care therapies and in earlier lines of treatment. I'm Peter Hofland, and this is the Onco'Zine Brief. The Onco'Zine Brief is developed in collaboration with our online journal Onco'Zine at Onco'Zine.com, where you can find additional information and the latest news about cancer, cancer diagnosis and treatment, and cancer prevention. For more information on how to support the program, visit our website at Onco'Zine.com. And if you're living in the United States and want to receive our newsletter, text the word cancer to 66866. And we will make sure that you'll receive our newsletter, which includes an overview of the latest news in oncology and hematology. Now on the phone with me are Dr. Ajay Nooka and Dr. Suzanne Trudel. Welcome to the Onco'Zine Brief. The annual meeting of the American Society of Hematology in December 2020 is now more than a month behind us. But due to the ongoing COVID-19 pandemic, the meeting was online. It was a kind of a different meeting, and I can truly say that I missed the interaction with experts and key opinion leaders, the sharing of ideas and asking questions. I guess something we take for granted when we are going to those meetings, right? So how was this for you?
Yes, that would be absolutely correct. We do a lot of interactions with our colleagues when we're at the meeting, and it can be very creative. You're talking to folks, you can get some really good ideas, and that part was really missing from the meeting.
I agree with Suzanne. Like, we do a lot of interactions, but in fact, this is the closest one could do for a live meeting. Ash has done a wonderful job in bringing everybody together, and I wish it comes back to the live meetings again, but this is the closest that I could think of at this point.
But the most important thing, the presentations and study updates, they were all there. Now, last year was a very difficult year with the pandemic. It seemed that everything was COVID. But other diseases don't stop because there is a pandemic. So, how did the pandemic impact your work? Were you able to conduct clinical trials, or did you have to cancel studies? Dr. Trudel?
Well, we've been lucky enough, at least in Toronto, not to have, we slowed down accrual for a period of time from March to June. There were some studies that didn't require hospitalization. We were able to continue to recruit to. Since June, though, we've been full busters continuing on with our studies. And in fact, when we look at our numbers, we were able to recruit just one less patient this past year than the year before. So we were still very successful in getting patients on study. I mean, these drugs that we have to treat myeloma now are amazing, and the patients are really benefiting. So it's really important to be able to continue the research.
Our experience is no different than Suzanne's. This is absolutely a time where, as you pointed out briefly earlier, the disease never stops, so should the advancements be. And we were halted briefly for a period of around 6 weeks or so until we could get a real handle of the situation. So from March 15th till the 1st of May, we held doing our transplants, but we never stopped off any of our clinical trials. We kept enrolling. In fact, last year has been one of the best years in terms of the number of patients that we enrolled on the clinical trials altogether. So, which is good for our patients and which is good for the advancement of science.
Other than wearing masks for protection, did you see changes in the way how patients participating in clinical trials were coming to your centers? Were they more hesitant? Maybe as a result of the pandemic, they were a little bit kind of worried? Dr. Trudel?
Yeah, there has been some hesitancy for the patients, but I think once they come to the cancer center, we're lucky enough to be a separate building, and we've got very rigorous procedures for screening people at the door. I think there's been a lot of comfort. We have reduced dramatically the number of patients that we're seeing. A lot of them were doing virtual visits, probably about 60 to 70% were doing virtually. So that's reduced the number of traffic through the hospital and the waiting time in the clinics. That's been very comforting for the patients.
And how was this in your center, Dr. Nooka?
Suzanne has brought in all the good points in terms of like how we try to increase the comfort level for the patients in terms of trying to screen every patient that goes in the outpatient setting as well as the inpatient setting. In the outpatient setting, anybody that has any kind of a symptom is not allowed into the cancer center, so which really increase the comfort level for the patient to come into the cancer center. At the same time, what we have always done was during this pandemic, we had the requirement to get down 30% of the clinic volumes so that those patients that are not on the trials or on the trials who are on oral medications that could be evaluated through a telemedicine visits, all those have been incorporated into the situation so that we are not overcrowding the waiting areas, increasing the risk of these infections. Fortunately, all these efforts have really rolled out well. No nosocomial COVIDs that I could see or we have reported in any of the settings, both in the inpatient and the outpatient settings, so which is always good. One of the main things that I applaud or how we learned through the pandemic is the regulatory processes in terms of the deviations and everything. If a patient has to come to enroll on a clinical trial, most of these patients have to bring in the monthly urines on the clinical trials and come in for monthly visits and a physical examination. Some of them are redundant, which clearly the pandemic has showed that not as much of a rigorously what we do in the regular clinical trials is necessary. There are some that absolutely need, but most of the redundancy we were able to reflect in terms of minimizing those visits and yet never compromise on the patient safety.
And what about your personal safety? When you're working with your patients, did you have to change your routine?
Yes, I mean, we're wearing both masks and face shields when we're interacting with the patients. We, as mentioned, if the patient doesn't really need a physical exam, we don't examine them. So it's been quite, I don't think any of my colleagues have had any COVID from the hospital through the outpatient clinic. It's been very safe. And thankfully enough, we've been lucky now to get the COVID vaccine, which certainly takes a little bit of the pressure off from us to know that we've been vaccinated.
Now, let's look back at the annual meeting of the American Society of Hematology. What were some of the things that you noted, some of the highlights for you, things that you think were important? Let's start with you, Dr. Nooka.
I think overall in ASH, despite the ongoing pandemic, we had a great successful ASH in terms of newer studies. There's an explosion of cellular therapies. There are good targets, good drugs with the BCMA as a target, with good newer targets like the GPRC5D, 5CRH5. All these have really shown us that we will find a way of how to conduct or progress the research despite any obstacle or a hurdle that you're put through. To make the long story short, it's not just in multiple myeloma, it's across all hematological malignancies. that we'd seen an explosion of the studies and newer advances. We're very fortunate to have that aspect in terms of not only the cellular therapies, but also good precision medicine in terms of targeted therapies that identifying the molecular targets and identifying the mechanisms of how you can exploit those molecular targets, paving way for precision medicine. So we have seen studies in across all hematological malignancies, good advances that I was proud of to be a part of.
Let's take a break, and then we're back with Dr. Ajay Nooka, Associate Professor in the Department of Hematology and Medical Oncology at Emory University School of Medicine in Atlanta, and Dr. Suzanne Trudel, Associate Professor in the Department of Medicine at the University of Toronto and an attending physician at Princess Margaret Cancer Center. I'm Peter Hofland, and this is the Oncozine Brief.
Sarcoma. Odds are you've never heard that word before. But for the 40 people diagnosed with sarcoma every day, it is a life-changing word. Life-changing and devastating because sarcoma is cancer. Sarcoma is a cancer of bone and soft tissue more prevalent in children than in adults. More than 6,000 people lose their lives to sarcoma each year. Treatment options for sarcoma are limited, and new therapies are desperately needed. More research and increased awareness is necessary to find a cure for a cancer that you probably didn't even know existed until now. Through awareness, advocacy, and research, the Sarcoma Foundation of America is determined to help those affected by this forgotten cancer, to bring hope to the children and adults whose lives are forever changed by a word they had never heard before. Please help us in the fight to find the cure for sarcoma. For more information on sarcoma and the work of the Sarcoma Foundation of America, please go to curesarcoma.org.
This is the Oncozine Brief with Peter Hofland.
And welcome back. I'm Peter Hofland, and this is the Oncozine Brief. You have been involved in clinical studies of BalanceMap Methotrexate, commercially known as Blendwrap. This is an antibody-drug-conjugate, or ADC, indicated for the treatment of adult patients with relapsed and refractory multiple myeloma. Now, before we're going to talk about these studies and before we're going to talk about the drug, can you briefly tell me, in general, what are antibody-drug conjugates, or ADCs? Dr. Trudel?
Antibody-drug conjugates are antibodies that target antigens. There's a number of antigens that have been evaluated in myeloma or are under investigations. The one that has excited us the most so far has been targeting BCMA. The antibody has a warhead attached to it that is a cytotoxic drug, induces cell kill. And so the ADC will basically act as a targeted missile to deliver the cytotoxic agent directly into the cancer cell. And we're fortunate enough that BCMA is an amazing target because its expression is really restricted to plasma cells, plasmablasts, and to a lesser degree, plasmacytic dendritic cells. So it's a highly selective target that's really not expressed on most tissues, meaning that, we don't get a lot of off-target toxicity from it. And then we get to deliver very high levels of a therapeutic drug into the cancer cell. There are new antibodies or ADCs coming along. They may differ in their warheads, and the different warheads will basically predict to some degree for toxicity. The toxicity profiles will be different depending on what the warhead is, and also to some degree potency as well. And some of these antibodies have been modified to enhance not only their direct cell kill, but their immune effects. So they retain classical antibody functions, so they can induce antibody-dependent cellular cytotoxicity and anti-dependent cellular phagocytosis. And in the case of belantamab, it can also induce immunogenic cell death. So it has multiple modes of action, which makes it, I think, such an ideal drug that has shown good efficacy in myeloma.
So, if I understand correctly, you refer to the antibody as the targeted mechanism with some specific antibody function still intact. And attached to that is a cytotoxic or cancer-killing agent. You call that a warhead. But I understand that some people may also call that a payload. which is attached to the antibody, lifting along with it to get into the cancer cell. Is that correct?
Yeah, I think you've said that very nicely. So we can call that a warhead, a payload, but that is sort of the important for inducing direct cell death. So it differs from naked antibodies like daratumumab or isatuximab that we use in multiple myeloma that targets CD38. These are really dependent on the classical antibody functions to induce anti-myeloma activity. This is ramped up with this extra molecule attached to it also induce direct cell death.
Early in the program, I referred to two studies presented during the ASH meeting or American Society of Hematology meeting, the Algonquin study and the DREAM-6 study. Dr. Trudel, you were involved with the Algonquin study. Out of curiosity, where does that name come from?
Yeah, so in Canada, we have a national park not too far from where I live. It is called Algonquin Park, and the study was named after that.
Tell me a bit more about the Algonquin study.
Yeah, so the goal was to improve the activity of the pomalidomide and dexamethasone. So pomalidomide is an immunomodulatory drug. It enhances immune responses in patients with multiple myeloma. It was approved now many, many years ago based on a phase 3 study that showed that the response rate was 30% with a progression-free survival of only 4 months. Since then, we know we've been using pomalidomide and dexamethasone in combination treatments, and that has resulted in improved responses as well as progression-free survival. So we wanted to build on POM and DEX and improve its activity. And the other thing that we wanted to do was use the ability of pomalidomide to enhance the immune system to essentially improve the immune-mediated effects of belantamab. So that was sort of the rationale behind the study. So the purpose was really to first look at safety of the combination, and secondly was to look at the activity, both overall response rate and progression-free survival.
If you look at the outcome of the study with BalanceMap Methotrexate or Blendwrap, as this drug is known commercially.
Yeah, much easier to say Blendwrap, right?
Absolutely.
So I forgot to mention one of the other aims of the study was really to look at the safety, but also to try to determine what is the optimal schedule for dosing the combination of Blendwrap with pomalidomide and dexamethasone. We'll probably talk about this a little bit more, but one of the common side effects of Blendwrap is that it induces corneal toxicities. Patients get blurred vision, and that is due to the specific warhead that is attached to Blendwrap. And we did see this as an issue in the study. So we basically, the study's been taking time because we've been looking at adding on different schedules and different dosing of Blendwrap in combination with pomalidomide and dexamethasone, where we want to see if we can preserve efficacy, but yet reduce the issues with the toxicity, particularly the corneal events. So at ASH, we reported data on 37 patients that have been enrolled, and those patients have been enrolled in different cohorts. And the cohorts, as I mentioned, will be different based on the dose of Blendwrap, the schedule of Blendwrap we use. And that study is ongoing because we're still working on optimizing the schedule. We know that the combination is highly effective, but now we're really focused on trying to make the toxicities acceptable for patients. And this will hopefully inform the dosing schedule for the DREAM-8 study, which is a phase 3 study.
Before we're going to talk about the DREAM-8 phase 3 study, there was also the DREAM-6 study. Dr. Nooka, tell me about this study and the study results.
As you had seen how DREAM-2 was approved, so I'll talk about the DREAM-2, then talk about the rationale of why a DREAM-6 study was initially designed, and then talk about the results and the safety in this aspect. DREAM-2 was approved in patients who are refractory to a immunomodulatory agent, a proteasome inhibitor, and an anti-CD38 monoclonal antibody, like Dr. Trudel previously alluded to, the daratumumab. So when patients become refractory to these three agents, the best overall survival or the best outcomes that you can expect is in the range of an overall survival within months, like 6 months to 8 months is what the current landscape looks like. With all the cellular therapies playing in this area, we potentially can see it much, much longer. So that's where the DREAM2 study really helps for us to understand the landscape and what this BalanceMap as a single agent was able to offer in this space. So the good things in terms of the long-term follow-up, the 13-month follow-up was presented at ASH, and which showed that the duration of response with a salvage agent, with a single agent treatment at 2.5 milligram per kilogram, that's the approved dosing, given over 30 minutes or every 3 weeks, the duration of response is in the range of 11 months. So the overall survival for these patients is close to 14 months. And this is in a space where we didn't have too many options in the past. So that is where the DREAM2 has cemented the role of BalanceMap in this specific space. Now, just like what we see in the drug development in multiple myeloma, so we've seen this with every agent that was approved, you have the efficacy and the safety established in a space where we don't have too many options. And if once you understand what the safety profile looks like, once the efficacy looks like, you traverse the regimens to earlier lines of therapy, including to the newly diagnosed setting. So where BalanceMap was evaluated in the DREAM6 with bortezomib dexamethasone is in the early relapse setting. These are no longer the patient in the late relapse setting, but early relapse setting or bortezomib sensitive. So the study was aimed to look at the safety and the efficacy of the dosing approved, that is 2.5 milligram per kilogram, administered as a single dose and given in combination with bortezomib and dexamethasone. Bortezomib and dexamethasone backbones have been studied in the space for a long time. For example, the CASTOR trial had a similar design. CASTOR trial evaluated daratumumab, bortezomib, dexamethasone versus bortezomib, dexamethasone. So the bortezomib, dexamethasone, the schedule is very similar to what was done in the other studies. It was given at a dose of 1.3 milligram per meter squared, given on days 1, 4, 8, 11. And the dexamethasone is given at 20 milligrams on the day and after the day of Velcade. So BalanceMap is tested in the first 6 patients with this combination at 2.5 milligrams per kilogram given every 3 weeks in combination with bortezomib dexamethasone. And once it was shown to be efficacious and safe, it was moved on to an expansion of another 12 patients. So that was the data that was presented at ASH. And among these 18 patients, so clearly what we were seeing is a high-risk patient population that was seen in 5 of these patients. And the safety profile is extremely predictable, similar to what we had seen with the combinations in the past. What we were able to show was the corneal toxicities greater than grade 3 were not too increased in the combination of bortezomib dexamethasone, and the rates were in the range of 60%, as we had seen previously.
Let's take a break, and then we're back with our interview with Dr. Ajay Nooka and Dr. Suzanne Trudel. I'm Peter Hofland, and this is the Oncogene Brief.
Clinical trials allow researchers to introduce new hope by providing participants access to cutting-edge and potentially life-saving treatments. Speak with your doctor and visit standuptocancer.org/clinical trials to learn more. Together, we can stand up for all of us.
This is the Onco'Zine Brief with Peter Hofland.
If you're just joining us, this week I'm talking with Dr. Ajay Nooka, Associate Professor in the Department of Hematology and Medical Oncology at Emory University School of Medicine in Atlanta, and Dr. Suzanne Trudel, Associate Professor in the Department of Medicine at the University of Toronto and an attending physician at Princess Margaret Cancer Center.
Now, the 2 toxicities that are of utmost interest when you look at treatment with a monoclonal antibody or the infusion-related reactions, which are not as high. There are only 17% of the patients that experienced a grade 2, and none of the patients discontinued the treatment because of an infusion-related reaction. The other toxicities that were seen were the thrombocytopenia, and these are most of these are reversible when you stop off the treatment. So the corneal toxicities again were predictable, no grade 4 toxicities, and these are very well manageable with appropriate dosing mitigation strategies, with holding up the dose when there is a toxicity, and an appropriate algorithm was followed through the protocol to make sure that it is done in the safest way possible. So with this approach, we're seeing an overall response rate of close to 78%. And most importantly, patients who got a response really had really good response. The VGPR rates are close to 70% or so. What's more interesting, and that was presented at ASH, was by the lines of therapy, if you look at, so these are early lines of therapy, right? If the patient has progressed very early on at the first, after receiving one line of therapy, they had an overall response rate of 100%. The patient had 2 lines of therapy, it was 67%. If the patient had 3 lines of therapy before enrollment in the trial, their overall response rate was 50%. So the bottom line is, the earlier that an agent like this can be exposed to, you get the best bang for the buck.
One of the side effects of BalanceMap Methotrexate includes, as Dr. Trudel mentioned, ocular toxicities. What did you see in your study?
So the keratopathy is very clear based on, number one, the warhead, as we were previously talking about. It is a toxicity with the MMAF, which is the warhead in this specific aspect. We were able to show from the DREAM2 study, I'll quickly move to DREAM2 to talk about the long-term ocular toxicities. Only for one reason, we had dealt with every myeloma drug with a specific unique toxicity. If you go back to using the proteasome inhibitors, neuropathy was a big deal when using bortezomib. So every drug has its own adverse event profile, so including carfilzomib having some cardiac toxicity. So what has become more of an issue with belantamab is the eye issues or the ocular toxicities. It becomes a little sensitive issue when it comes to the eye. So that was why it has become a more prominent question in terms of the toxicities. So in ASH of 2020, what was shown from the long-term follow-up of DREAM2 was not everybody who has a keratopathy will have a clinically meaningful decreased vision. So if there's a clinically meaningful decreased vision, it is absolutely of concern for me. I would not want to put my patient at risk for any of the drugs that we have that has a potential for doing that. But here, even though 60% of the patients have a keratopathy, only 18% of them have a clinically meaningful decrease in the vision. And even among these patients, every patient has, all the patients that have been followed have recovery of their vision, and there is no permanent loss of the vision. So this would be my take-home message at any point. There is no permanent loss of vision when you are exposed to an agent like this. And absolutely, appropriately offering all the supportive treatments and making sure that we don't dose among these patients is the key. But by offering the agent, an effective agent, you're not compromising on the vision in the longer run is very key from the findings that were presented at ASH.
So the takeaway for both studies is that the side effects are serious but manageable. And in a majority of cases, it is also reversible. Dr. Trudel?
I would say so. I mean, it is a common event. People have to understand when they read the data what the data means. So there was 72% or 70% of patients who develop what we call keratopathy. Keratopathy is just changes in the cornea that the ophthalmologist sees on exam of the eye. That does not necessarily mean that people are symptomatic. About 50% of patients actually had symptoms, and that could be blurred vision, dry eye. And as mentioned already by Dr. Nooka, is that only about 17% of patients had a meaningful decrease in visual acuity, and that would be considered 20 on 50 or lower. And then those patients, when we hold the drug, give them a bit of a break, the corneal toxicities recovers, the visual acuity improves and we can usually resume dosing. So I can tell you from my experience with the Algonquin study now, we have some patients that are 2 years now on their treatment. They have had some eye toxicities on and off, but overall, none of them have come off because of eye toxicity. They continue on treatment. And sure, they get these occasional episodes of blurred vision, but it does recover. And, so this is, 2 years of follow-up we have in these patients that remain on treatment. And some of those patients are in complete remission. Some of them are MRD negative. And this is the best response we've ever had in some of these patients.
Now, BalanceMap Methotrexate is used in combination with other drugs to treat multiple myeloma. How important is the treatment of multiple myeloma with a combination of drugs?
So this is a great question, Peter. It goes back years ago when we were using 2 drugs versus 3 drugs. So we did not have a lot of options at that point. So we were using steroids as the backbone for every regimen in multiple myeloma. We're adding an extra drug. So these are the bortezomib dexamethasone, like I mentioned before, pomalidomide and dexamethasone, Dr. Trudel mentioned before, so lenalidomide dexamethasone. These are all doublet regimens that we were using in the past. So now over the last, I would say 4 years or 5 years, we've seen an explosion of immunotherapeutic agents and other second-generation agents like the pomalidomide, the carfilzomib, have been evaluated in combination with the backbones, say PI plus an IMiD backbone. I'll give you the example, KRD versus RD, so that is carfilzomib lenalidomide dexamethasone versus lenalidomide dexamethasone in the ASPIRE trial. Similarly, using the same backbone, in the Eloquent study, elotuzumab dexamethasone versus elotuzumab, lenalidomide dexamethasone versus lenalidomide dexamethasone, or the Pollux trial with daratumumab, lenalidomide dexamethasone versus lenalidomide dexamethasone. All the 3 drugs were compared against the 2 drugs, and similarly, other trials compared bortezomib dexamethasone backbone versus the combination with the third agent. So when we compile all these trials together, there is not even a single trial that had shown equivalent efficacy for 3 drugs versus 2 drugs. Every trial had shown superiority for the 3 drugs versus the 2 drugs. So which has ultimately made the 3 drug in a relapse setting as a standard of care. So the combinations of drugs to attain with a goal to eliminate the clonal process to the lowest level is the key to keep the patients from progressing over a long run. And now we have newer testings, like looking at the MRD testings, which are extremely common to see with a 3-drug regimen among patients who achieved a stringent complete response or a CR with a 3-drug regimen. You also have the possibility of attaining those MRD negativity. So now these can never be talked about in the days when we're using those doublets of the 2-drug regimens. So the 3 drugs have become the standard of care in the relapse setting, and the same combinations continue to move further or advance further.
Dr. Trudel, when you look at BalanceMap Methotrexate, what do you see as the potential future for this drug compared to, for example, other agents or drugs that also target the BCMA, like BalanceMap Methotrexate?
There's lots of advantage to an antibody-drug conjugate as compared to other modalities that also target BCMA, such as the bispecific T-cell engagers and the CAR T-cells. It's off the shelf, so patients can be in the office. We see them, the disease is progressing, we can start them tomorrow. It can be given in the office. It doesn't require admission to hospital. Also, it's not associated with life-threatening toxicities, such as what we see with the CAR T-cells, the cytokine release syndrome, the neurotoxicities, and, significant infections that can occur over time with patients who get CAR T-cell therapy. So I think that for a lot of physicians in the community, particularly, this is, going to be, it's easy for them to use it. Some of the bispecifics and the CAR Ts need to be predominantly given at an academic center currently because of the risk and the requirement for hospitalization. So I think it's really important that we continue to work with ADCs and incorporate them in myeloma therapy just that being one reason is the ease of convenience for patients. And I think really the key is going to try to be able to figure out how we can potentially reduce the incidences of corneal toxicity. So one of the aspects of our study is to look at less frequent scheduling of giving the drug. We looked at a loading dose and then immediate step-down dosing. And I think if we can work out the kinks, especially when it's used in combination treatment, we may not need to give it so frequently, and we may not need to give as high of doses. And I think if we can get the corneal toxicity to be at a more acceptable range for patients, then, I think that really this is going to be a drug that could be moved up to the frontline setting.
Let's take a break. And then we're back with our interview with Dr. Ajay Nooka and Dr. Suzanne Trudel.
The Centers for Disease Control and Prevention is encouraging cancer patients and survivors to be extra cautious during the COVID-19 pandemic. Cancer treatment, especially chemotherapy, weakens the immune system, making you at higher risk of severe illness. Dr. Lisa Richardson is director of the CDC's Division of Cancer Prevention and Control.
Take these steps to stay healthy. Wash your hands often with soap and water. Clean and disinfect frequently touched surfaces daily. Stay home. If you must leave, keep at least 6 feet between you and others. Avoid touching your face, eyes, nose, and mouth with unwashed hands. If your temperature is 100.4 or higher, call your doctor. Use CDC's coronavirus self-checker to help you make decisions about seeking medical care.
Make sure your caregivers and household members are aware of your higher risk and take precautions. Visit cdc.gov/coronavirus and preventcancerinfections.org for more health tips.
This is the Onco'Zine Brief with Peter Hofland.
If you're just joining us, this week I'm talking with Dr. Ajay Nooka and Dr. Suzanne Trudel. I'm Peter Hofland, and this is the Onco'Zine Brief. That means personalized treatment to meet the patient's specific needs?
When patients are getting it in combination, maybe we don't need to use the 2.5 mg per kg dose. Maybe we can use a lower dose because we're not relying on the antibody alone to do all the work. And we're hoping that the activity of the antibody is enhanced by the combination that we're putting on. Similarly, maybe we don't have to dose it as frequently because, again, we're not relying just on the antibody to hold the patient's disease in remission, so we can less frequently dose the drug. There are potentially other avenues, such as basically blocking the cleavage of BCMA from the cell surface of the myeloma cells. So normally BCMA is shed from the tumor cells and it circulates, and it's possible that the high BCMA levels in the circulation act as a drug sink. So there are studies now combining with these molecules that can basically prevent the cleavage of BCMA on the cell surface, thereby increasing the expression of the target on the cell surface. And again, maybe you'll be able to use a lower dose that may have associated less corneal toxicities. So, we know that this drug is a very effective drug, very easy to give. And aside from the corneal toxicities, patients have actually really minimum other toxicity, and it is generally very well tolerated. What we need to know now is strategies, and I think there are a number of strategies that could be used to reduce the risk of corneal toxicity and impacting the patient's vision.
Just like with many complex diseases, there are many unmet medical needs. What kind of need and potential treatment options do you see with multiple myeloma?
One of the places where I see a need for a lot of treatment options, or an exploration of treatment options, especially that have an immune mechanism by which it acts, so is probably in the precursor states. If you look at, to give the landscape, every myeloma originates from a precursor state called MGUS, which is a very small clone, which as the clone expands over a period of time, becomes smoldering multiple myeloma. We have given those definitions based on the amount of the tumor burden. Over a period of time, the clone is harmful and it is causing damage to the host. And that's when it needs to be treated according to what we went through in terms of this transition from myeloma to smoldering multiple myeloma to symptomatic multiple myeloma. So now there's a lot of factors that go in. It's not just the tumor, but the microenvironment and the immune factors that affect this transformation or the expansion of the clone from each of these disease states. So there are more than a few studies in the recent years that had shown an early intervention in the high risk and the moderate risk smoldering multiple myeloma space is able to prevent the transformation to multiple myeloma. There is one study that provided the initial proof of concept that patients should be treated early. This was a Spanish study that was published in the New England Journal of Medicine almost 7 years ago in 2013. It came with a lot of flaws, and at the time, the imaging was not as much well utilized. So there probably may be some patients with active myeloma that were on the trial. So that was the biggest criticism for the trial. Now, the same study without the lenalidomide and dexamethasone as an intervention among these patients was done in the U.S. by the ECOG study using lenalidomide alone, and the patients were treated until progression to symptomatic myeloma. So now, if you look at the results of this study, these were really impressive for the intervention group, showing that the risk of transformation is significantly decreased by an early intervention. That's probably where the immune function is much better, and the drugs might work really well to prevent myeloma. And this potentially, so whenever you're treating a situation where the current treatment is observation, you need a really good safety profile to be established. So it's a two-step process. The first step is exactly as Dr. Trudel pointed out earlier. We need to find out the right dosing that has the minimal corneal toxicity to be given to a patient, probably in the induction setting, in the early lines of therapy. And then once you're able to prove that, move on to the smoldering space. So that is probably where, at this point of time, there's a huge emphasis that needed to be placed to prevent it at the first place. So there are other areas, just like what we see in the post-CAR T-cell space. That is the second area that I feel that there is a lot of need for development of new drugs, and that is potentially where BalanceMap can be explored. The third area that I can think of is in combination with the naked antibodies. So one can think of, if you look at targeting one antibody as a one target like the BCMA, you are literally the residual clone that is left out is the one that is not expressing BCMA, right? So if you're using an additional target, it will probably eliminate whatever the minimal or the residual clone is, and that potentially can help with making the patient stay in remission for a longer period of time. The area where I'm thinking is potentially combination with the other naked antibodies or even other antibody-drug conjugates that are not targeting BCMA. So those are the places I can think of as the unmet needs and where there's a space and potentially can be explored.
Dr. Trudel, do you see any other unmet medical needs and treatment options to help improve the lives of patients with this type of blood cancer?
Well, I think all of those are very valid needs that were highlighted by Dr. Nooka. I mean, the other needs are the high-risk patient population. We have about 20% of myeloma patients who do very badly no matter what we do with their treatment. And at least in the DREAM2 study, when they looked at what was considered high-risk patients based on certain genetic factors, those patients seemed to benefit just as much from treatment as those that were not what we call cytogenetic high risk. So, exploring these types of treatments in high-risk populations, it certainly wouldn't be given as a single agent in that setting, but working on trying to find what is the best partner for this particular ADC or other ADCs, and looking at them in a high-risk patient population would also be something that's of high need.
In addition to BalanceMap Methotrexate, what other developments in multiple myeloma excite you?
It's a targeted medicine is what probably helps me and excites me all the time. If only we can identify a biomarker, so we're making every drug a personalized drug or more towards a precision-based aspect. So in our center, we use venetoclax, which is a BCL2 inhibitor for translocation 11-14 patients. This is probably the first place where we are choosing a patient, a specific treatment based on the cytogenetic abnormality that the patient has or the patient's myeloma has. Similarly, identifying biomarkers for each of these treatments to see which is the pure clinical phenotype that will respond so well to this specific treatment is the key, and that potentially excites me the most. And potentially we'll be able to find a good biomarker for the BalanceMap.
And Dr. Trudel?
Yeah, my research focus is really on early drug development. And, we were so impressed with the data that we're seeing with drugs that are targeting BCMA. And it's really unbelievable now that we have bispecific T-cell engagers that are targeting other molecules, FCHR5 and GPR6, which are also showing very high levels of activity in myeloma. So there's more coming for patients, and that is, we're unbelievably lucky and to have these new tools to play with. And as mentioned earlier, I think we need to better understand these drugs work really well now. We have really good tools to play with and treat patients, but we have to understand why they fail. And, the advances in genomics with, single cell sequencing, where we could really try to hone down on both the immune microenvironment and the patient's tumors to try to define why patients are becoming resistant to treatment, I think will also change the landscape for the better.
And with that, I'd like to thank you both, Dr. Trudel, Dr. Nooka, for being here with us in the Oncocene Brief.
Thank you, Peter.
Thank you.
In today's edition of the Oncocene Brief, I spoke with Dr. Ajay Nooka, Associate Professor in the Department of Hematology and Medical Oncology at Emory University School of Medicine in Atlanta, and Dr. Suzanne Trudel, Associate Professor in the Department of Medicine at the University of Toronto and an attending physician at Princess Margaret Cancer Centre. We spoke about transformative therapies being developed for patients diagnosed with relapsed and or refractory multiple myeloma, and study results for BalanceMap Methotrexate, commercially known as Blendwrap, an antibody-drug conjugate developed by GSK. For more information at BalanceMap Methotrexate, including highlights of prescribing information, visit blendwraphcp.com or, and this may be easier, blendwrap.com. For more information about GSK, the developer of the drug, go to gsk.com. For us here at the Oncocene Brief, we want to thank you, our listeners, sponsors and advertisers, for your ongoing support. Your support makes it possible that you can hear this program via PRX, Public Radio Exchange, and in the United Kingdom and mainland Europe via UK Health Radio. And you can also download this program via podcast and streaming media, including iTunes and Spotify. For more information about supporting the Oncocene Brief, go to Onco'Zine@oncocene.com. If you're living in the United States and want to receive our newsletter, text the word cancer to 66866, and we will make sure that you'll receive our newsletter, which includes an overview of the latest news in oncology and hematology. Thank you all. And thank you for listening. And join us again for our next episode. I'm Peter Hofland, and this is the Oncocene Brief.
The Oncozine Brief is produced by Sun Valley Communication in association with Physicians Weekly and the American Association of Medical Education. Support for the Oncozine Brief comes from listeners of this station and our commercial underwriters and advertisers. For more information about advertising, underwriting, and sponsoring options, visit Oncozine at www.oncozine.com/underwriting. The Oncozine Brief contains health and medical-related information and is provided for educational and entertainment purposes only. The content in this program is not intended as a substitute for professional medical or health advice and does not replace your doctor's advice and guidance. Your doctor is the best person to answer questions about your personal health. If you hear something in this program that doesn't agree with what your doctor has told you, ask him or her about it.